Wonderful. Hi, everyone. Thank you for joining us today for a preoperative testing work group featuring MyMichigan Medical Center Saginaw, formerly known as Ascension St. Mary's Hospital. My name is Christy Degner, and I am a site engagement coordinator for MVC, and I look forward to facilitating this work group for you all today. So for today's presenter, we have Jenni Kinder. Jenni has been a registered nurse at Ascension St. Mary's in Saginaw, now known as MyMichigan Medical Center Saginaw, since 1987, with 20 years in cardiac care and 10 years in nursing education experience. Her transition to data-driven work began with a hospitalist performance group in 2017, then to her current quality improvement role as an SCQR with Michigan Surgical Quality Collaborative since 2020. She earned her Bachelor of Science in Nursing from Saginaw Valley State University in 1987 and her Master of Science in Nursing from Walden University in 2016. A self-described data nerd, she enjoys connecting and coloring the dots to communicate the big picture message. Before we pass it over to Jenni for her presentation, I have a few housekeeping items to review. Jenni, thank you for being here with us today.
Thank you.
So first, the session is being recorded. The slides and the recording will be shared with all attendees following the work group in an email. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We'll also have some designated time at the end of Jenni's presentation for a Q&A session. Lastly, your feedback is very important to us. If you could please complete the post-work group survey in a link that will be provided in the chat, as well as in that follow-up email, that would be greatly appreciated. As a reminder for hospitals participating in MVC's component of BCBSM's P4P program, in order to get credit for this work group, the survey is mandatory. So without further ado, I will pass it over to Jenni for her presentation, and I will stop sharing my screen for you now, Jenni.
Okay. How did that do?
Looks good.
Okay, very good. Well, good afternoon. I'm Jenni Kinder, and my role with MSQC is a mouthful, as Christy said, Surgical Clinical Quality Reviewer, or SCQR, for my newly transitioned site, MyMichigan Medical Center Saginaw. And as you see from my bio, I've been with St. Mary's in Saginaw for decades in a number of roles. Today, I'll share our team's journey to reduce unnecessary pre-op testing in the specific population of low-risk patients having elective low-risk surgery. So, objectives. I'll review our project's performance, strengths, and challenges, discuss assessment, planning, implementation, and evaluation, illustrate use of data sources, discuss common barriers, summarize recommendations, and time for Q&A as well. And as the slide says, I have no conflict of interest or relationships to disclose. Baseline performance. So as you can see in the slide, in 2023, we were testing almost 92% of our low-risk gallbladders and minor hernias. Nowhere to go but up from there for sure. Of note, our data does not include any breast lumpectomies because those cases are done at our ambulatory care center, and that site is not captured in MSQC abstraction. So the pie graph clearly shows room for improvement. And in a matter of months, we had improved from 92% to 72%. Another few months, we were at 62%. And cases closed at year end were roughly 55%. So how did we get there? We were fortunate to have a small group of engaged stakeholders, and I believe that our baseline testing data of 92% spoke strongly to each stakeholder's sense of duty to act quickly on the safety and quality initiative. Another process strength was a timely update to the pre-op testing worksheet. This clarified and communicated ASA status preoperatively, and I'll talk more about this as we go. Our main strategy and strength was developing a simplified decision tree. Our surgeon champion recognized a testing crossroads of sorts, where one discipline, either surgery or anesthesia, needed to be responsible for testing so that the decision tree and process could be simplified. And anesthesia was willing to lead this charge. So we modeled our decision tree after the decision aid resource from MProve MVC MSQC partnership, making it very user friendly. So if you follow me down the left-hand side of the tree, it starts at the surgery office with elective cases. Is this one of those, gallbladder or hernia cases? And if yes, the office provider would order pre-op testing per anesthesia protocol at the time of booking. And then, our next stakeholder, who really helped to pull this together, was pre-procedure testing office, who worked, Crystal, who worked closely with the anesthesia chief. The next decision really was to look at the patient's comorbidities to decide their ASA status. And we needed a simplified way to get to that decision. So using some of the resources we had, our definitions were no comorbidities would be ASA 1, 2 or more comorbidities, and a hemoglobin A1C 7 or less would be considered ASA 2. And then you can take a peek on the right-hand side, 3 or greater comorbidities. The patient would fall out of this left-hand side. But if the patient was ASA 1 or 2, that qualified them for no pre-op testing. And of course, provider judgment could always be enacted at any time. Challenges. Change is never easy. It's easy for key stakeholders to come up with a plan, but then it has to be introduced, educated, cultivated on the front line at the right time with a couple of loop back around. And many things influence that. Hospital culture, interdisciplinary relationships. Those two things sort of pave the road of change that we're going to travel. Is it going to be smooth or a bit bumpy? It's interesting. We had significant change in our stakeholders mid-project. A new anesthesia group came on board with Ascension, and I recall this brought differences in ASA interpretation that had to be navigated. And I'll talk about that a little later in the slides. I'll even show you where there was a trend where our ASA population changed or the ASA designation evolved. Then there were crickets, radio silence. All seemed to be going well with agreement on the decision tree, proposed process, and launch date. And I was going to present it at one of the standing department meetings. But I still had no formal email final approval until the 11th hour the night before we rolled it out. So that was a bit unnerving, but we made it through. Project phases: assessment, planning, implementation, evaluation. Those of you who are nurses will recognize the API acronym for nursing process, and you can apply it to just about any process. And assessment was the biggest piece. We looked at performance data, stakeholders, detailed the current processes, looked at existing protocols, and anticipated barriers. Anytime you're working on a change project, you kind of foresee or some of the problems that might come up. Keep those right with you, because you can be navigating solutions along the way. So we had performance data from several different sites, from MVC, MSQC, and then concurrent site data. So MVC data. Excuse me, I was not familiar with the format of the MVC reports. So this was a little learning curve for me, but I dove in. For starters, I saw that it was old data. I'd already, felt a little uncomfortable about reporting data that was 90 days or, a year old. What was I going to do with data from 2019 to 21? But my initial concern soon changed because this retrospective view, I soon realized it was valuable and indisputable data that we were consistently, increasingly testing our pre-op patients. And to use a road trip paraphrase, we were going the wrong way. So there was no doubt that we were not on board, not doing the right thing. Here's a couple other type of reports from MVC. And the benefit of this, it compared our sites to other Ascension sites and other sites in the collaborative. And I've blinded the data, so you're not going to see, names or scores on there. But it shows where each site falls in comparison to the rest of the field. And the second table gives some context to be able to compare with other sites of different sizes. I left our site's data in this particular table. And if you can see it, it says we had 55 gallbladders, 33 hernias over the 3-year period. And I was like, that doesn't sound right. And, I questioned the data, and I knew my stakeholders and audience would question the data. So I scrubbed the data until I understood it. I compared it to MSQC data from the same time period, data that I had entered into MSQC. And when I filtered by insurance, the numbers matched. What I'd pulled from the MVC numbers matched the volume of patients that I pulled from MSQC who were Blue Cross payers. And this comparison rang true for our site because the majority of our patients are Medicare and Medicaid, not private insurance. So in summarizing our performance data from MVC, we ranked highest in testing before inguinal hernia repair, third highest in testing before gallbladders, and third highest overall in pre-op testing. Pretty convincing baseline data from MVC. This data scrub was quite time consuming, but I believe it helped hook the stakeholders into action as well as gain confidence in the data validity. This is the report from MSQC, the baseline report. It's a dynamic graph depicting prevalence of pre-op testing, ASA class, delineation of gallbladders and hernias. And, this is our baseline data, and we received other reports along the way. And I think this type of detail captured stakeholders' attention. But we know that MSQC reports and data are relatively retrospective. And retrospection is not the best window for improvement. So I found it beneficial to track progress concurrently and by developing a site-specific pre-op testing dashboard to derive performance graphs and to provide a more concurrent view of performance. So brace yourself for an onslaught of data. And people who know me know this is what my things look like. Let's look first at the vertical table on the right side, and you can kind of see 3 sections, 3 snippets. I realize they're not evenly cut, but we're going to look for trends. So looking first at the blue bars in the center of the table, compare the top section. There's about 15 blue bars and about 20 in this lower section that is obviously smaller. So along the way, we had more blue bars at the bottom, and blue represents, so you can look on the bigger slide, ASA 2 or 3 cases with no testing or testing excluded from an ED visit or day of surgery. Those are the exclusion criteria. And, you can see that not only were the green ASA 2 patients having no testing, but look at all the ASA 3 patients that were not having testing as well. And so we saw that spillover effect. That was very beneficial. Let's look again at the tall graph on the right, looking at green. This represents ASA 2 cases. And the pre-op testing decision tree, remember, required identification of ASA status early in the steps. This required more attention to ASA status and agreement among the providers about a working definition. So, intended or not, there was an increase in ASA 2 status designation. You can see, what do we have, like 5 green bars up here, and by the time you get to the bottom, that's probably about 10 or 12. So that was that transition I was talking about, intended or not. And then these bright pink bars, greater at the top, less at the bottom, depicts a definite decrease in PCPs or specialist ordering tests before elective surgery. Easy to see the progress there, as well as showing it in this matter easily addresses a common concern from providers and PCPs that PCPs were ordering pre-op testing. So we did educate PCPs on this initiative, and it seems to have had a measurable impact. So I would say use your data to show trends within your facility. Scrub it, speak to it, then strategize from it. Most of you are likely well past the assessment stage, but if you're struggling with engagement or strategies, consider looping back to assessment. Each site's patient population varies. Know your population, inpatient, outpatient, population health issues. These unique factors will guide your approach. Assessment of stakeholders. Common stakeholders for this initiative are surgeons and their offices, anesthesia providers, pre-op testing, pre-op clinics, whatever you call it at your facility, and quality department. Keep asking yourself and your team members, is there anyone else who should be on our team? And in our case, there was a major change in anesthesia stakeholder with the transition to third-party anesthesia group mid-process. So that was a bit of a shakeup, but we seemed to get past that pretty well. Assessment of processes. I remember we looked very closely, step by step, of what the pre-op procedure testing department did, and how they identified ASA status, and with that clearly established, that they were such big stakeholders, I really had to get their buy-in. And digging a little deeper into their process helped us foresee a gap in establishing and documenting ASA status. So bridging this gap early on became one of our strengths. Existing protocols. Think of it as rules and roadmaps for your trip. What are your current pre-op testing protocols or guidelines, such as pre-op order sets, anesthesia pre-op protocols? Thinking back to our strengths, updating the pre-op procedure testing page or the blue sheet was a game changer. I was so excited when we accomplished that. Anticipated barriers. I've already shared a couple of barriers and strategies to barriers, and I'll have more examples as we continue. Moving on to planning. Our assessment findings showed us where our clear starting point and opportunities were, starting with case qualification, picking a primary decision maker, and a process for ASA status determination. And then a soft rollout by our surgeon champion and a few providers at her office seemed to have less resistance and less stress before a full launch, and it provided for adjustments. And even a soft launch even makes me less nervous. Stakeholders, keep asking who are the primary owners. Is everyone represented on our team as you continue to plan? And then new tools. The simplified pre-op decision tree was our main tool, and I eventually added MVC and MProve support pieces to it for education. So shout out to the cross-collaborative partnerships for providing great teaching slides and protocol examples to educate and implement change. And education, our decision tree and pre-op form were our best tools. And the multidisciplinary stakeholders took these messages back to their departments, for education. And then I began to use the decision tree itself as an educational tool because I received several requests for, hey, can I have another copy of the decision tree? So I added key MVC and improve support pieces to it as education. And then on the previous slide was common barriers. There were differing ideas among providers about whether a test was necessary. And this was where a tool for defining ASA class and a resource for testing recommendations was helpful. Again, those types of resources were provided by the partnerships. Another barrier, look at, are there any current protocols or guidelines that are going to cause some process conflict? Will one group, if there's conflict in the processes, will one group concede to the other? And in our situation, we were lucky that anesthesia was willing to, take the lead with testing from that point, and the surgeons were willing to partner in that way. Testing ordered by PCP. As I showed you in some of the previous slides, I quantified this anytime there's a concern. I think if you quantify it, put it in a graph, give it real-time data, that concern kind of goes away. Or you recognize that's a real concern and what can we do about it? A strategy to address resistant providers, maybe who've been around a long time. Comparison graphs, such as the ones I showed, can speak volumes. Back on those real, busy tables that I had blinded. I could tell you who the surgeons were in those cases. I blinded it for display. But if that was what we needed to do to speak to the issue, I could unblind that data. Or if your culture doesn't support identifying fallouts or unblinding data by provider, consider a graph that depicts outliers by surgery type. There's ownership in that type of reporting as well. And then crossing lanes. If you're getting resistance from particular disciplines or stakeholders, you might need to let someone else drive. Meaning pull in assistance from someone who's in their lane, whether it's hospital administration or your surgeon champion to help with providers. Maybe they don't like the way you drive, or somebody else should give them directions to where we're going. Implementation, set a launch date, do a practice run, and make adjustments. And then clearly identifying your next meetings kind of keeps things rolling. And then you've got your footwork to do to have updated data to display at a regular basis. So you really know what your performance data is so you can intervene. A shout out to MSQC, a double-edged sword for mandating a number of multidisciplinary meetings in this pre-op project. It was helpful. Well-planned meetings are a catalyst for progress. And then evaluation. Spot checks and check-ins. As the quality lead for this project, I regularly measured progress and reported results. This is where my concurrent tracking dashboard came in handy. I was able to make graphs from all that busyness. I also had scheduled check-ins with my surgeon champion like every other week. If you get it on the calendar, it helps to make it happen. And as I said before, I also shared data at standing meetings such as Department of Surgery meeting, surgical governance. I shared with the PCPs through the internal medicine newsletter. Those were some of the ways I shared the data. And then strategies. The strategy that worked best for us was identifying barriers and adjusting accordingly. And this usually included real-time education and letting the performance data do the talking. I also upped my data graphing skills. I used feedback and questions from presentations to better define my pie graph slides with, well, what's the goal on there? And so, you know, that came a long way from my initial graph. Expanding, how are we doing now? There was inherent expansion of the practice evidenced in overspill from improvement in many of the ASA3 patients. So again, now we have no testing being done in a lot of ASA3 patients. And I also verified with the pre-op testing department that there are other pockets of low risk procedures with no testing as well. Summary and recommendations. I would say know your stakeholders and your patient population. That really helps to strategize. Build on your strengths. I think our collaboration between anesthesia and surgery really made our decision tree possible. Anticipate and strategize response to barriers. Again, providers were concerned that, well, our numbers are up because PCPs are ordering this. I got on that right away to be able to provide the data and reel that in. And then let the data do the talking. Respond to resistance with evidence. Scrub the data, speak to the data, strategize from it. And lastly, keep bringing the stakeholders to the table. If you're having difficulty in your multidisciplinary meetings, I've seen it in my past roles. Keep bringing the players to the table until something shifts. Any questions?
Wonderful. Thank you so much, Jenni. That was extremely informative.
Great, thank you.
What questions do we have for Jenni today?
I have a question. This is Lisa from Sparrow. Can you hear me?
Sure. Yes, we can hear you. Hi, Lisa.
Hi. How difficult was it for your meetings to get the surgeons engaged and actually attend your meetings? Did you include all your surgeons in the meeting, or did you just have a few from, I don't know how many offices you have, like the lead surgeon from each office, or how did you?
Yeah, that's a great question.
How did you get those surgeons engaged and come to the meetings, I guess? And how often did you have your meetings?
So I had meetings every other week with my surgeon champion, and then she took it back to the main surgery office. We also collaborated with another main facility. Oh, I'm getting my project mixed up. So having that lead person from each facility surgery office, that's a real challenge, but it's also the key to getting the information there. Another area where I experienced success was being able to present directly to a surgeon's office, not necessarily about this project, but about a different project. And, you know, being able to show the data the way I know it, I think was a game changer and different from the way the provider representative would speak to it. So if you can get in-person time at that facility and show convincing data, I think that would really be helpful. Did that answer your question?
Sorry, can you hear me?
Yes.
Yeah, it did. I just didn't know if when you had your meetings, you had invited all the surgeons, or you mainly had a main person who then disseminated it to the rest of the surgeons.
Yeah, a main person to disseminate, but again, having any of the players, you know, would be welcome. Thanks, Lisa.
Hi, this is, oh, I'm sorry.
No, you go ahead, Jennifer. Thank you for speaking up.
Oh, thanks. I'm Jenni from Corewell Health, Farmington Hills, and I just wanted to add on to what you said, Jenni, that we have a SQIPS committee with a chair, co-chairs, and some surgeons in there. The challenge that they face is if the PCP is ordering all this extra testing and it falls within the 30 days of surgery, they're dinged for it. So they want to know, how can the PCPs get more engaged in this
Mhm.
um,
Mhm.
idea for pre-op testing and et cetera?
Yeah, you're absolutely right in engaging the PCPs. So, let me ask you, do you think they know, what do you think they know about this, reducing pre-op initiative? Do you think they're aware of it?
Yes, I do. They're
Okay.
on board. We have a
Okay.
champion and a chairperson
Okay.
on this.
The PC from the PCP office or from the surgeons?
Oh, I'm sorry, from the
Yeah.
surgeons in the hospital.
Yeah, well, that's a great first, that's a great foundation to have your main partners engaged. And do you have an idea of the prevalence of the PCPs ordering within 30 days? Like, do you have any idea how often that's happening?
Quite a bit because a lot of them have to get clearance for their surgeries
Mm,
from their PCP and then they just order the testing. And
yeah.
again, if it's in our chart, it's
Mhm.
gonna,
Sure.
even if we give paperwork that says we only want these labs in a clearance, they're still gonna order everything,
Hmm.
it seems like.
Yeah.
So
And do you,
that's our biggest barrier and challenge, I
mm,
think.
yeah. I appreciate you asking the question. I think that it was an issue for us, that I was able to reel in, and the strategy that I used was presenting directly to internal medicine through I wanted to attend the meeting. But instead they had me just give us some snippets for the newsletter. So that was the only level, that was the kind of a basic level of education for PCPs. So think about at your facility, what is the means of communication? Is there like a Department of Internal Medicine? Can you present, or could your surgeon champion present? Um, at that venue, because then you're getting the message directly to the PCPs. And if I would be glad to help you work through creating something beautiful like this. Really, I think if you could show how often it was happening, then it really does put ownership on the PCPs
Right,
to reel it in.
yeah,
Your table would look a lot different than mine. So,
excellent. Thank you, Jen.
yeah, you're so welcome. Sounds like you already have some great work and support, and those barriers are frustrating, but you have to, do you have someone from the PCP group, at your table?
No, and there's so many outside
Yeah,
the
yeah,
hospital arena, so
yeah,
um
that is a challenge.
we're
Start
talking
somewhere.
about redoing our package that they are taking to their PCP for medical clearance for surgery.
Mhm.
And that's still under development though, of
Okay.
to drive that point out there to say these are the tests that we need
Right.
and not required for this surgery,
Mhm. And
kind of hammer it home.
right. I also wonder if these are patients needing PCP clearance. Are they low risk patients? Are they ASA 1 and 2? How far into the ASA 3 might they be?
Right.
Um,
And they're
so
looking at
maybe
that
they,
too.
yeah, some crossroads there, really. Interesting. Thank you.
Thank you so much to both Jennies. So we have a few comments in the chat. We have one from Jonathan Lee. I may have missed it, but did you experience any pushback on the decision tree? Often people I interact with are wary of things being too simple because we work in a complex process, complex environment.
Mhm. Um, There was no external pushback, but I can say from my standpoint, I was concerned about, are we making this too simple? There's a reason that look at the cardiac issues, the testing decision aid that came from the partnership, MVC Improve. Um, we basically took that piece out, so we could get rolling. Um, so I think your question was, what kind of pushback? I thought that might be a barrier. I thought, are we making this too simple? And that came from me. So we really did not get any pushback about it being simplified. Did I answer the question? Or did I just turn it around? Sorry.
You did. Thank you so much.
Okay, great, John. So I had some trepidation about it. But in hindsight, that's always the best rear view mirror. I see that it was the simplicity of it that really let us just run with it. And once you get started, I think starting is the hardest part. So, that tree could be, that tree is now part of our process. And then if we needed to expand it to capture maybe ASA3 patients with other comorbidities, then we can add on to something that was already simple that we were familiar with. So I think simple is good because you can always make things more complicated.
That is for sure. We do have a question too from Cameron. Can you provide your email, Jenny? And we were planning to include that in the follow-up, if that's okay with you, if people have
Sure.
individual follow-up questions they want to connect
Yeah.
with you afterwards.
So would they get that from you?
Yeah.
Okay, very good.
I can give them your MyMichigan email, your new email address.
Yes, thank you.
And then I did want to point out Emily, who is a site engagement coordinator with MVC as well, just put in the right size testing website, which has a PCP package under the resources page, which includes a letter with language directed to PCPs about unnecessary pre-op testing before lower surgeries. So that would be a good option as well to connecting with those local PCPs.
Yeah,
Thanks,
agreed.
Emily. Wonderful. Well, great discussion so far. Does anyone have any other questions for Jenny?
I actually have a question. Hi, Jenny. This is Jessica, the engagement manager. Just curious. Great job. Great presentation. I love your driving metaphor. Just curious about when you were going through the implementation of this, and I think you already mentioned hindsight is, of course, 2020, but are there any big pieces where you feel like you would have, if you were to do this again, you would do something differently, or major lessons learned as like sort of cautions for your peers that you would like to share?
I think I would have to go back to focus more on what went really well. In hindsight, I don't think that nothing really is coming to mind of, oh, I wish we'd done that differently. I think we could have improved our PCP and surgeon engagement, beyond just a leadership person. So I think that's opportunity. Maybe still untapped opportunity. But the numbers seem to have fallen in line. So maybe the word did get out. So I appreciate the question, and I think we were really on track to where our opportunities were, and had good things happen for us. It was time. When you're testing 92% of your patients, you better get on it.
Great point. Great
Yeah.
point. Thank you.
Mm-hmm.
Thanks for that question, Jessica. We do have another comment from Amy in the chat. I love the pre-op testing ASA decision tool. This would have been wonderful when we started our project. We may have to reevaluate this area. It's good to hear, Amy. Thanks for your comment.
Amy, I'm glad you brought that up because I think that helps me answer Jessica's question. I think that probably was one of our biggest hurdles. Not only did we not have a solid ASA determination tool. I mean, anesthesia did. Just through experience, they knew what their designation was. But it was a challenge when we brought in a second, a third party anesthesia group. And then, so then our ASA, then we really needed a tool. So, and that was pretty simplified. I know that the resources give a much broader view. But again, that was, I think that was one of the keys to getting us rolling, because you could always give added attention to a patient and do the testing if something in their history warranted that. So I agree with you. You know, maybe you could look again at your definitions and go with something simple like that. I didn't have any fallout or backlash on here's what happened from that simple those simple definitions. I didn't hear anything back about that not going well. But I respect the risk in assigning somebody a lower ASA. That's where risk comes in here.
Wonderful. Thank you, Amy, for your comment, and Jenni for your comments as well.
Great. Thank you.
Do we have any other questions for Jenni before we conclude today?
Hi, this is Monica Sinkowski. I want to say great presentation, Jenni. I know the challenges because I worked on the same project. Felt your pain. Congratulations on the job well done.
Great. Thanks, Monica. Great to hear from you.
Jennifer in the chat, echoing what Monica said as well. Great presentation, Jenni. And I will echo that as well. It was a wonderful and informative presentation. Thank you so much for joining us today and taking the time to present that awesome work. It was great to hear about your journey. And like Jessica said, I did really like that driving metaphor as well. That roadmap, you know, you may get some blocks and stop signs in the way, but you keep on going.
Sometimes you have to get off the sidewalk too.
Yep. Wonderful. Okay, so if no one has any other questions, we will conclude the work group for today. But before we do that, I am just going to share my screen again and bring up some upcoming events and share the remaining work group date for pre-op testing for the year. So let me go ahead and share my screen. Okay, wonderful. So as you can see on the screen here, we do have one remaining preoperative testing work group for this series, and that is going to be on November 5th from 12 to 1 p.m. A link to register is also included on this slide here. And as a reminder, in order to receive the full 0.25 points for the work group series, you must have attended all 4 work groups in this pre-op testing series and been a part of the work group for at least 80% of the session. So moving into some of our upcoming work groups, we will round out August with a cardiac rehab work group on August 22nd, and Corewell Health Farmington Hills Hospital will be presenting their cardiac rehab program. So we're excited for that. And then in September, we have a post-discharge follow-up work group where Trinity Health Oakland Hospital will be presenting. That will be on September 10th. As a reminder, all work groups occur virtually from 12 to 1 p.m. And with all of that, thank you so much for joining us today. Emily, if you wouldn't mind posting the link to the survey in the chat, everyone can grab it there. We also will be including the email, the link to the survey in an email following the work group. So if you can't grab it in the chat right now, we definitely will be sending that out as well. So you'll have it. Awesome. Well, thank you so much. Thank you, Jenni, for presenting. Thank you, everyone, for attending the thoughtful discussion. We hope you have a great rest of your day. And I will be including Jenni's contact information as well as ours in the follow-up email as well. So if there's any questions that come up after the fact, I'm sure Jenni would be happy to answer them. Have a great day, everyone. Thank you so much.